This program is brought to you by Emory University.
Okay, great. Thank you, everyone, for joining. Good morning, and I'm going to take my mask off. Now, we are starting to meet in person, so this is our first GrandRounds in person, starting April. To start off with Dr. Dan Sorescu, who is an associate professor of medicine here at Emory in the Center for Heart Failure Therapy and Transplantation. Dr. Sorescu is board certified in cardiology, advanced heart failure and transplant, and echocardiography. He got his medical degree from Bucharest in Romania, and then residency in internal medicine at the Beth Israel Medical Center at Albert Einstein College of Medicine. And then he trained under Dr. Kathy Grinling and spent a couple of years doing vascular biology and was a basic science cardiovascular research fellow here, subsequently clinical fellow at Emory. Dr. Sorescu has had a very, very productive sort of career path. He was heavily involved in basic science research and had received funding from AHA and also an R01 to study cardiac fibrosis. And then he switched over to 100% clinical and has given over 100 talks on various topics related to heart failure and more recently, echocardiography and heart failure. He continues to be a manuscript reviewer for top-tier journals such as the American Heart Association journals, European Heart Journal, Journal of Cardiac Failure, Circulation Research, et cetera. And really, he has received so many awards, especially teaching awards. I think I counted about 6 or 7 Golden Apple Awards for teaching, and also Millie Pub Club Awards ×2, which those of you who know, that's an award that's given when you've got a publication that receives over 1,000 citations. So it's just absolutely amazing. And I remember rounding as a fellow with Dr. Sorescu at Midtown, and I have to say that it's very memorable. It's something you don't forget. And today we're going to have him talk to us about a tale of salt and sugar, SGLT2 inhibitors, and CVD disease. Dr. Sorescu.
Thank you, Pooja. Really, Emory has been my home now, and basically I feel part of the Emory family for over 20 years, actually 21 as faculty and 24 total, including cardiology fellowship. So I thought I would discuss today the impact of the new class of drugs, the sodium glucose transporter type 2 inhibitors, which are drugs that basically as cardiologists and heart failure physicians, we kind of stole it from diabetes, particularly in the heart failure field. We're going to talk about the potential mechanisms, how these drugs work. We're going to review the clinical trials that have shown impact on cardiovascular outcomes in both heart and kidney, actually, and we'll review the updated guidelines on heart failure, how this has been impacted by the SGLT2 inhibitors. First, I would like to review what we know about prior rest of the diabetes drugs in and cardiovascular disease, and there are over about 11 different classes. So far we know that metformin, in actually very few randomized clinical trials that we have, appears to be superior to insulin sulfonylurea. It's good at reducing macro and microvascular complications in type 2 diabetes. Really the most, until SGLT2, the GLP agonists have shown to have some impact on all-cause mortality and stroke, but really not, and cardiovascular mortality, but no effect on heart failure or actually other MACE events like myocardial infarction. And most recently, the SGLT2 inhibitors have probably the most dramatic effect overall to reduce either the MACE and progression of kidney disease, but also heart failure independent of diabetes. And these effects, I'll state it, although there is some very modest reduction in blood pressure, about 3 to 5 millimeters mercury, hemoglobin A1C anywhere between 0.2 to 1, percent, and the effects appears to be actually independent of those variables. Metformin has been studied compared to insulin, and the only cardiovascular clinical trial that actually addressed the impact on overall MACE after myocardial infarction. This is the DIGAMI study, DIGAMI 2 study, where basically patients who just had a recent myocardial infarction and with diabetes, they were randomized to either metformin, sulfonylurea versus insulin-based regimens. And to everybody's surprise, actually metformin appeared to be superior in this study for 2 years follow-up in preventing MACE, but also overall mortality, most of it, interesting, related to cancer-related death, while the insulin-based regimens appear to have a twofold higher risk of new myocardial infarction. So this puts a red flag on our patients who actually require insulin as a follow-up in their diabetes regimen. As a matter of fact, insulin appears to be a risk factor also for progressive heart failure. More recently, the trials with glucagon-like peptide-1 receptor agonist, here there are 3. They show some improvement, I would say at most mild improvement in MACE-related outcomes, about 15% relative risk reduction, liraglutide, semaglutide, albiglutide, or dulaglutide. But really, when it comes to cardiovascular outcomes, recently, the glyphosine class, the SGLT2 inhibitors, like empagliflozin, canagliflozin, dapagliflozin, appears to have the most important impact we ever had, and actually in end organ damage in patients with diabetes. And this is actually, we'll see, mostly related to actually the impact in preventing chronic kidney disease progression, but also heart failure related hospitalization or mortality. So in conclusion, so far what we have is metformin appears to be still the gold standard as somebody who has type 2 diabetes, new onset, although this will be soon challenge. We have some major red flags with regimens that require insulin, sulfonylurea, or TZDs. As we know, TZDs have increased the risk, about 4-fold risk of heart failure related hospitalization in those patients who are on diabetic drugs. So far, GLP receptor agonist appears to be safe, but most of the impact is not related to heart failure, is related to some MACE events, mostly stroke prevention. The DPP inhibitors, sitagliptin and others, really so far actually have been negative. They pretty much just reduce the hemoglobin A1C by 1%, and they do nothing else. If there is anything, we have 2 trials with sitagliptin that show that actually, although small trials, show that actually may be worse outcome in patients who have heart failure. And really the most important that we're going to focus for the rest of the lecture will be the SGLT2 inhibitors. So before we go there, we need to think about the mechanisms, how this works. It's fascinating that it starts as a way of increasing the basically glucose excretion in the urine. That is the hypothesized mechanism. And yet, improvement of 25% overall outcomes in both cardiovascular and renal disease seem to be out of proportion with that. And we're going to talk first about the cardiac effects and eventually about the renal effects. But basically, the hypothesis is that we have a glyphosine that blocks the sodium glucose transporter 2 in the kidney. This is in charge of over 90% of glucose reabsorption in the proximal tubule, which occurs with sodium reabsorption. As a consequence of that, about 75 grams of glucose or sugar are excreted daily, which is equivalent to about 500 calories And really, that leads to increase to cardiovascular protection. However, it's difficult to understand how we get such a dramatic improvement in heart failure-related mortality if there is no receptor of this glyphosate on the heart. As a matter of fact, most of cardiology researchers have hypothesized that the main reason how this works is got to be a way how the SGLT2 inhibitors actually affect the cardiac remodeling, which we know has been associated with improved outcomes in heart failure. For example, this small study of 10 patients, they were randomized, they were given empagliflozin, 25 milligrams a day. They were followed 3 months later, and this is echocardiographic data shows that you have actually 3 months later an improvement not only in the diastolic dysfunction, but also in the cardiac hypertrophy. So this effect is so quick that it's got to be some kind of way of how this works. And in order to understand that, I think I'm going to show you a vision where these patients, actually, we need to figure how this started. And these patients started, I would say, at the large scale by being exposed to what we call ultra-processed food, which is a diet that is rich in saturated fat, fructose, and very low in fiber. The first station from the gut is the liver that sees there is excessive calories. This needs to be stored. It knows that only the liver and the fat itself can store, and switches to a storing mechanisms where it's going to start to produce triglycerides and store them in these organs, but at the same time, it's going to send insulin-resistant signals to the rest of the organs like heart and muscles and brain, which are not able to store. And this is pretty much the first stage is insulin resistance. But the first really stage is the liver. You get fatty liver. The second stage will be insulin resistance. With time, this process is ongoing, and basically the rich gets richer, where it comes to calories and fat storage, where the poor gets poorer. You get more and more insulin resistance to peripheral organs, particularly heart. As a matter of fact, the association between fatty liver and cardiovascular outcomes and actually coronary disease has been well known. Basically, this is a small study where everybody who had coronary disease underwent cath, and you can see that the incidence of fatty liver, it goes up it's about 85%. And then with triple vessel coronary disease, it was up to 100%. Basically, if we were to look now in general population, about 25% of across the country have fatty liver. In type 2 diabetes, the association is about 70%. If you have pre-diabetes, about 50%. And patients who undergo bariatric surgery, it's about 95%. As a matter of fact, our own Dr. Larry Sperling, who is the chief of our preventive cardiology here at Emory, has suggested that fatty liver should not be thought as an independent entity, but it's an entity that is part of the greater metabolic constellation risk. I was going to propose to you that really fatty liver is the main essential stage of cardiometabolic disease. And it starts, of course, with initially morbid obesity, insulin resistance, and fatty liver. The second stage is the heart starts to get sick. Initially, probably just a heart failure with preserved ejection fraction. Once you start to develop other associated conditions that are associated with dyslipidemia, coronary disease, severe refractory hypertension, sleep apnea, atrial fibrillation, then a lot of these hearts will develop dilated cardiomyopathy and heart failure with reduced ejection fraction, whether it's ischemic or non-ischemic. And then last but not least, the last stage, when we actually, at this stage, we start to have symptoms once the heart involved. And the third stage is actually when our patients start to come in the hospital and have mortality related is kidney failure. And if we think this as a progressive disease over 10, 20, 30 years, and we think of these stages, then I think the story comes a little more clear of how potentially these medications that we've developed work. And you'll say, well, this I'm not sure how this applies to our clinical trials and the patients that actually population we study in the clinical trials. And first of all, currently about 73% of everybody in this country is overweight. Morbid obesity being now in about 20% of anybody younger than 20. And they have also not just obesity, but also insulin-resistant dyslipidemia. If we were to see this kid and somebody with the same numbers and somebody who's 50 years old, we'll say this is tremendous risk for coronary disease. And most recently, actually, in our SGLT2 inhibitor trials, for example, the DECLARE TIMI56 and CANVAS trials, well, turns out the average patient who was enrolled in the trial has a BMI of 32, which is considered morbid obesity. So these are actually patients that we do enroll in that trial. Unfortunately, all these clinical trials have excluded patients with a BMI, less than 45. So this is becoming extremely clinically relevant, and I think it becomes important to realize what's that while we develop drugs to target each and every mechanisms of how this happens, it's good to keep in mind the bigger picture of how this actually develops and try to work on that too with lifestyle changes. So if I were to pick up a villain from what causes fatty liver, dyslipidemia, fructose, and then is, of course, we know about the saturated fat, but really fructose is the main culprit for fatty liver. There are only two ways how actually we can get fatty liver right now, particularly NASH, non-alcoholic steatohepatitis. One is alcohol, which used to be number one, but now is actually fructose. Fructose is metabolized actually by the liver exactly like alcohol. It's perceived as unnecessary calorie that is actually metabolized straight to triglycerides. And according to Dr. Lustig, is the number one cause right now of fatty liver and probably cardiovascular disease on top of the saturated fat. So basically, about 10 years ago, we wanted to look into developing a model of mouse murine model of cardiomyopathy related to type 2 diabetes. And I went to Dr. Frank Anania, who's expert in the field of NASH and who's now at NIH. And basically, he had a teenager mouse model where at 4 weeks, mice were fed with this diet that was equivalent of a burger a day and some high fructose corn syrup, 2%. This simulates and causes fatty liver in these mice within 12 to 16 weeks. And I said, well, I'll look into the heart. And basically, we found that indeed we can reproduce in about 16 weeks everything that we know in humans in over 20, 30 years of life or more. Basically, they get dyslipidemia, high blood pressure, elevated uric acid level. They eat and they keep gaining weight, and they have insulin resistance. And when we look at the heart, to our surprise, within 8 weeks, these mice start to develop actually dilated cardiomyopathy with an equivalent by 16 weeks of ejection fraction drop about 30 to 40% just by switching to this diet. And when we look in the heart, actually, within 6 weeks, they had evidence of insulin resistance upon exposure to the diet, as evidenced here by phosphorylated AKT reduction in the fasting state in those mice. And also, when we look in the liver, they had fatty liver. Then we want to say, okay, what if we try to fix the fatty liver? What happens to the heart? And Dr. Anani actually gave liraglutide, GLP-1 receptor antagonist, to these mice. And the liraglutide indeed was able to partially reverse fatty liver, insulin resistance, glucose tolerance, but we also reversed cardiac hypertrophy. So this proves that it's not just about once you get cardiomyopathy related to, or suggest that once you get cardiomyopathy related to diabetes, maybe the main signal starts from the liver. And looking into potentially connecting that to fatty liver and mechanisms that may help us to improve cardiomyopathy too. Basically, when I did a genetic molecular analysis of what's happening with the cardiac myocyte phenotype, it turns out that we convert within 16 weeks a healthy adult cardiac myocyte phenotype to actually a fetal cardiac phenotype that's extremely similar to cardiomyopathy from any etiology, whether is ischemic or non-ischemic cardiomyopathy. Literally, the hearts after 16 weeks, it looked exactly the same like we look at somebody who's got advanced cardiomyopathy, independent of etiology. And basically, also the heart looked like it was a starving heart by downregulating mitochondria, ATP synthesis, enzymes, glucose transporters, fatty acid transporters. So really, this actually has been studied in detail recently, and it turns out when you expose somebody to a gluten kind of diet, and when there's liver perceives there's excess of calories, the insulin resistance signal that's sent to the heart triggers switches the metabolism of the heart from a active cardiac myocyte contraction size to a storage type. And basically, we turn off the signals that are required for fasting states, such as sirtuin and cyclic AMP kinase, and we turn on the enzymes that actually switch the heart to a proliferative phenotype. It's like under the influence of renin-angiotensin activations and others, the heart remembers what it used to do in the fetal life. In the fetal life, we actually have lack of nutrients. It's hypoxia, 3% is about 20%. Heart can only use glucose and nothing else. And angiotensin 2 triggers that fetal phenotype transformation, which is great for a fetal heart because the pressures for that, it's 5 times lower. It doesn't really have to be strong. It can afford to have an ejection fraction of 30% under 5 times lower afterload. But this is highly inappropriate on an adult heart, which has much higher afterload. So basically, in these hearts, whether it's ischemic or non-ischemic cardiomyopathy, we know there's early activation of neurohormones. And what seems to have both diabetes and heart failure have in common, they both have activation of sympathetic nervous system, renin-angiotensin system, aldosterone, and neprilysin, which on the diabetes it leads to microvascular disease, but also in the heart failure progression. And other things that both diabetes and heart failure have in common, the progression of the kidney disease in diabetes and progression of heart failure are actually due to increased filling pressures, increased intraglomerular pressures with hyperfiltration for glomerulus and increased left ventricular and diastolic and right ventricular and diastolic pressures for heart failure. As a matter of fact, the treatment that prevents end organ damage in both are identical and the same. So in a way, at molecular level, both diabetes and heart failure, but also its mechanisms are identical and the same. So basically, Dr. Packer suggested that really heart failure is the most important, earliest, and the most preventable and treatable cardiovascular complication of type 2 diabetes. And as a matter of fact, the outcomes in SGLT2 inhibitors, the most profound impact was actually in preventing the heart failure admissions and hospitalization. So then we started to look at heart failure and diabetes being so similar. We started to look at diabetes drugs. Unfortunately, from all diabetes drugs we have so far, only the SGLT2 inhibitors appear to be able to do the job. And so the question comes, how does a drug like empagliflozin is able to have this impact on a heart without having any receptors in it? And really, when we study a little more carefully, it turns out that actually we don't have any SGLT2 receptors in the heart, but we do have sodium hydrogen exchanger. Turns out the sodium glucose transporter 2 and the sodium exchangers, they have binding sites, both have binding sites, and they work next to each other. As a matter of fact, you cannot separate sodium or glucose transport across the cell membrane without each other. So the truth is, this is a tale about sodium and sugar, salt and sugar, because that's how our body processes it. They're not process independent. And so then the question is it possible that most of the beneficial effects in cardiomyopathy and renal protection or even liver are related to this by blocking the sodium hydrogen exchanger? So what does sodium hydrogen exchanger do? Well, it turns out that it's extremely upregulated in diabetes, but also in heart failure, both in the heart and the kidney. We have two different isoforms. One is in the heart, cardiac type 1, and the other one, type 3, is in the kidneys. The one in the kidney regulates most of the proximal tubal sodium reabsorption, which is over 70% of total sodium load. And they're both stimulated by angiotensin II and insulin, and also TZDs, pioglitazone. This is probably the mechanism how we have worse heart failure in patients with diabetes, those drugs. And this sodium hydrogen exchanger, the way it works is if you have any insult on a cardiac myocyte, anything that will tend to shut down the ATP synthesis, the elevated lactic acidosis, namely hydrogen, the cardiac myocyte is trying to prevent itself from acidosis. And immediately it activates this cotransporter to get rid of the hydrogen. And at the same time, the price it pays, the cell will have a tendency to become overloaded with sodium. Now, this excessive sodium is not good for the cardiac myocytes either. So in exchange, we're going to activate the sodium-calcium cotransporter. So at the end, all this, you get rid of the acid, but the price you pay, you get calcium overload inside the cell. Now, this increased diastolic calcium current is actually part of heart failure progression and cardiomyopathy, and switch to that phenotype and protein synthesis. So the hypothesis here that actually SGLT2 inhibitors, by binding to this sodium hydrogen exchanger, not just to sodium glucose transporter 2 in the kidney, actually are able to confer cardioprotection. So what evidence we have for that? Well, first of all, there is turns out that at least in the lab, when you do this in a rat or a mouse murine model, but also in the isolated human cardiac myocytes, SGLT2 empagliflozin is able to actually bind to this sodium hydrogen exchanger. As a matter of fact, post-MI model or diabetic models of animals show that not only binds, but also is able to block the increase in intracellular sodium concentration, but also prevent myocardial infarction scar increase. And more recently, in a rat model and murine model of with and without diabetes, it's able to actually protect against heart failure progression in these mice by activating an anti-apoptotic pathways. Both basic science data now and also clinical data are starting to suggest heavily that we're not dealing here with just an effect of blocking sodium and glucose transport in the kidney, but also direct effect either on the heart, kidney, and on the liver on sodium hydrogen exchanger. In a recent review article, Dr. Packer suggested that basically the SGLT2 inhibitors, which should be also called sodium hydrogen inhibitors, actually work by activating and providing cardiac and renal protection by activating a mechanism of SIRT1 and cyclic AMP kinase activation, which are usually activated in a fasting state. So there's a difference between fasting state and starving state. Fasting state actually provides us, protection by activating those mechanisms. Starving is exactly opposite. Another mechanism will be through direct sodium hydrogen exchange inhibition, and at least seemed to be very relevant in heart failure with preserved ejection fraction. These SGLT2 inhibitors can reduce actually by at least 30-40% of pericardial fat and inflammation related to that can lead to cardiac fibrosis from the epicardium. Basically, that suggests overall a potential beneficial effects on the clinical outcomes. But we also have more profound data showing that actually sodium hydrogen exchanger is essential for the effects of type 2 diabetes, both on liver and the heart. So we have sodium hydrogen actually exchanger knockout mice. Then they're exposed to diabetic diet, and then it turns out that when you look in the heart, it reduces the fat infiltration in the heart, reduces the insulin resistance, and it upregulates the mitochondrial-related genes and reactivates basically normal glucose and fatty liver utilization by the heart. And when you look in the liver, the same thing happens. You lose the mice lose weight, their insulin resistance improves, and also improves the fatty liver. So basically, this suggests that overall there's more important role for this sodium hydrogen 1 exchanger activation, both in cardiac myocyte biology, but also liver biology when we're exposed to this ultra-processed food that causes cardiovascular disease. We talk about potential cardiac mechanism. We're going to talk about the renal mechanisms here. Bottom line is, as much as we try to say that most of the heart failure benefits of these medicines are related to the heart, it turns out that the greatest impact actually was on kidney. As a matter of fact, we don't have kidney improvement, we don't have heart failure related outcomes in this study. So how does it work on the kidneys? It blocks the sodium glucose co-transport. And because it does that, there is more delivery of the sodium and the glucose to the macula densa. That actually reestablishes the tumoroglomerular reflex. The tumoroglomerular reflex is actually designed to match the sodium load in the distal tubule with the sodium load in the proximal tubule. And when you do that, it releases adenosine that actually vasoconstricts the afferent arteriole and reduces the intraglomerular pressure. But also as a consequence, these are the only diuretics that we have actually that will increase the uric acid secretion, actually will may help with elevated uric hyperuricemia related outcomes. Some other positive effects are not just losing weight, because you lose about 500 calories a day that way, but also increases the erythropoietin level, which is the significance is not clear, but definitely we have a lot of patients with progressive heart failure who have actually anemia related to relative deficiency erythropoietin. Now, what kind of diuretics or natriuretics are these agents? And if we were to compare, we give a loop diuretic, we know that we reduce both the intravascular but also the extravascular volume in these patients. But turns out when we look and compare with SGLT2 inhibitors, the intravascular volume is relatively preserved. You lose mostly the interstitial volume. So one of the mechanisms from their mild diuretic effect could be that it doesn't activate so much the neurohormones as a regular loop diuretic without activating RUS. And if we were to go back at how does it prevent the kidney disease progression, really the central hypothesis, at least in nephrology world, is that you have increased, once you have some kind of kidney damage, you have increased intraglomerular hyperfiltration and increased intraglomerular pressure per the rest of the nephrons, which eventually leads to further nephron loss. And any drugs, for example, ACE inhibitors or RAS inhibitors, that will reduce that intraglomerular pressure has been shown to actually improve renal outcomes. And in a nutshell, if we were to look at what happens, somebody's got diabetes or you have increased sodium, increased glucose in the proximal tubule triggers glucose and sodium reabsorption in the proximal tubule through the sodium hydrogen exchanger 3. That actually leads to lower sodium delivery in the macula densa, which is at the beginning in the part of the juxtaglomerular apparatus, which actually inactivates the tumoroglomerular reflex. So we don't have adenosine release that actually reduce the intraglomerular pressure, but the opposite, we have activation of renin-angiotensin, which actually angiotensin preferentially vasoconstricts the efferent arteriole and increases the GFR. While that is good to preserve the GFR, it's actually bad for the renal perfusion because then you have overall reduction of renal blood flow as a consequence of angiotensin 2 or insulin activation. Both the main effect of angiotensin and insulin in terms of sodium retention is actually shown to be, or is hypothesized to be, through the sodium upregulation of sodium hydrogen exchanger 3. As a matter of fact, we have two agents now that can block this sodium hydrogen exchanger 3 in the kidney. One is the SGLT2 inhibitors, but the other one is actually the mineraloreceptor corticosteroid receptor antagonists, such as spironolactone and plernon, but also most recently the non-steroid version, finerenone, that actually has been shown in 2 studies that actually prevents chronic kidney disease. We don't have a study for finerenone in heart failure, independent of diabetes yet, but hopefully we'll have that soon. We know they started, and we'll have an answer for that. So in a nutshell, the way it works, really blocking not only the sodium glucose transporter 2 in the proximal tumor, but also sodium hydrogen exchanger 3. You have a excessive delivery of sodium at the macula densa, which then reestablishes the tubular glomerular reflex. It causes actually adenosine release and vasoconstriction of the afferent arterioli, which reduces the intraglomerular pressure. But most importantly, I think it turns off the renin-angiotensin activation, the neurohormones. And that's probably the main mechanism that so far has been accepted how this works. And the effect is additive on top of our RAS blockade. Obvious, all these patients were in clinical trials. They had actually adequate treatment with either ACE inhibitors or angiotensin receptor blockers. And it leads to the same effect. No matter what we do, it reduces the intraglomerular pressure, which is the main driving force for progressive kidney disease. But there's more to it. And Biosync Sciences have studied in mice and in RAS model of diabetes. They gave dapagliflozin, and then actually in somebody with type 2 diabetes, they measure the renal angiotensin II production. Turns out it was dramatically reduced the moment you give these rats a diabetic type 2 diet. And not only that, but there is also reduction of inflammation, a reduction in glomerular damage, and also prevention of renal fibrosis. So this turns out works not just by preventing the immediate hemodynamic effects, but also by preventing the renal remodeling on long term, and that's part of preserving the glomerulus. So to summarize all this, putting it together, I said that actually, although we focus on the heart, really exposure to what we call a Western type diet causes the first stage fatty liver. The second stage causes insulin resistance and a diabetic heart, initially with preserve, eventually with low ejection fraction. Eventually, we get in the hospital and we have mortality once we have problems with the kidney. And SGLT2 inhibitors are actually able to work. We have data at the basic science level for fatty liver. We don't really have clinical trials outcome in terms of helping with the fatty liver, but we do have data now at the clinical outcomes level that prevents cardiomyopathy and helps with the kidney disease progression probably by preventing the negative effects of chronic insulin and angiotensin II activation in the liver, heart, and kidney. So that's the big picture. So now I'm about to review the clinical trials of SGLT2 inhibitors. And first of all, I want to point out that really, although we define American Diabetes Association defines diabetes as a stage where glucose becomes abnormal, hypoglycemia, it is well recognized that actually insulin resistance precedes by 10 years the end organ damage and coincides actually with development organ damage 10 years before you actually have overt hypoglycemia and we start treating diabetes. So a lot of disease process, at least in heart and kidney and liver, occurs way before we actually start to treat these patients with diabetic drugs. Based on the fact that we have now at least 4 trials that actually showed safety in terms of cardiovascular disease. Many years ago, drugs like TZDs and pioglitazone have shown to actually have worse trigger 4 times worse heart failure. So FDA require then all studies that study new diabetes, they have to show it's safe for the heart. And that actually led to these 4 trials, which were designed to show actually cardiovascular safety. And basically we have a dapagliflozin trial, the DECLARE TIMI58 trial. We have a CANVAS, kind of gliflozin based, and we have an empagliflozin based one. These 3 to the left are all about prevention and safety. Patients who have either established or high risk factors of coronary disease who were treated with dapagliflozin versus standard of care. And The last one I think is very relevant is actually more of a renal study where basically patients with either chronic kidney disease with a GFR between 30 and 90 or macroalbuminuria, at least 300, basically towards nephrotic syndrome kind of thing. They were studied to see if it prevents outcomes. And I like actually having a GFR-centric perspective. I actually think you can re-stratify these patients and you can look at their risk of cardiovascular morbidity and mortality by just looking at their baseline GFR. If we were to, I'm going to show you data and look at, just pay attention to this. According to this, patients with the highest risk in this population were actually the renal disease patients with a GFR 56%, while the others in order have a GFR anywhere between 85, 76, and then drop to 74. And turns out when we look at the cardiovascular outcomes and think as a cardiovascular and kidney disease progression, the biggest impact actually were in patients who had the worst GFR, and then the least impact were in the patient who had the most preserved GFR. By itself doesn't mean on long term, the one with the preserved GFR may not benefit, but the studies had to be stopped after 4 years because they showed benefits. So when we look actually from that perspective, the study were not designed to actually show, didn't have as a main endpoint cardiovascular morbidity and mortality, but turns out that most of these beneficial effects were due to dramatic improvement in both heart failure-related outcomes and kidney-related outcomes, the composite renal endpoint being need for dialysis, dying from end-stage renal disease, or doubling of creatinine, which is very relevant, clinical relevant. And if we were to put these patients on empagliflozin, just like with ACE inhibitors or ARBs, you would expect there will be about 3 to 5 ml GFR drop initially in the first 8 weeks. But eventually, if you follow these patients on long term, the placebo keep having worse GFR, where the patients who are on SGLT2 inhibitors are going to stabilize and actually reduce their risk of progression. So don't be afraid of that. This is a summary. I know it's a busy slide of all the studies. Other than those, we have now also a sotagliflozin-based study and ertugliflozin. I put here the ertugliflozin because for some reason, really the confidence interval for the ertugliflozin for overall composite was, it crossed the 1.1. The authors did not have a clear explanation, but it did improve heart failure hospitalizations. But one drug that seemed to be a little different is the sotagliflozin, which we don't know if it's going to be approved or not. It's an interesting drug, and I'm going to talk some more about it because it blocks not just the SGLT2, but also SGLT1. And it was studied the same way, either patients with diabetes and kidney disease versus patients who just had overall acute decompensated heart failure independent of systolic or diastolic dysfunction. But as of now, the guidelines, the American Diabetes guideline says that if you are somebody has type 2 diabetes, you're going to place them on metformin as a first line, and that probably is going to be challenged soon. And if you have predominant MACE or cardiovascular risk factors, you can consider either SGLT2 or inhibitor or GLP-1 agonist, receptor agonist. And if you have predominant renal disease, SGLT2 inhibitors. If you have heart failure, SGLT2 inhibitor. Now I'm going to look into clinical trials of the SGLT2 inhibitors in chronic systolic heart failure, because this is what I do for a living. And before that, I wanted to remind you, what do we know about diabetic drugs and heart failure development? And one is a big question about metformin. We have some clinical association with metformin potentially being beneficial in heart failure, especially if it's used by itself, not with sulfonylurea. Adding sulfonylurea actually makes it worse. And one of the main mechanisms how metformin is protective both for fatty liver and possible for cardiovascular disease actually activates the cyclin P kinase and sirtuin pathway. I was telling you, these are activated in fasting state. So even if you just ate, it fools the liver into thinking you're fasting, so it doesn't go into that storage mode. Sulfonylureas are actually bad. Insulin and TZDs, they're definitely not good for heart failure. As a matter of fact, anybody we know it's on high-dose insulin, they're in the hospital with heart failure. They have sodium, tremendous sodium and retention and water retention. And the main reasons, both insulin and TZDs activate these sodium-hydrogen exchangers, both 1 in the heart and 3 in the kidneys. GLP-1 receptor antagonists and FACC, we have two small studies of 300 patients that actually showed negative outcome when you look just at heart failure per se. So we don't know yet. There are, and the main reason is activates cyclin AMP and actually norepinephrine and sympathetic activation get tachycardia. But although there are some beneficial effects, it does seem to block, at least at the kidney level, or reduce the activation of sodium hydrogen exchanger. So we don't really have a large clinical trial about that. DPP-4 inhibitors, we have most of sitagliptins actually have at least 2 or 3 trials that show to be negative for heart failure, appears to activate this stromal-derived factor that actually stimulates the epicardia, fat-related inflammation, and also cardiac fibrosis, so that might be one of the mechanisms. And really, all we have so far is a drug that we stole from diabetes clinicians, and is the SGLT2 inhibitors. And in this declared TIMI-53 trials, if we look at who are the patients who benefit most from this, at least time to the first heart failure admission, turns out that mostly the patients who already had a prior low reduced ejection fraction. And there wasn't much benefit. There was a minimal benefit if they have a relative preserved ejection fraction, but they had no history of heart failure. There was very little benefit. So then basically Dr. Packer and others designed trials where we just look at heart failure, independent diabetes. About half of the patients were they were enrolled in actually the DAPA heart failure trial. We had diabetes, half didn't have type 2 diabetes. And to everybody's surprise, there was a tremendous ejection fraction, less than 40%. There was a dramatic and probably the most significant clinical trial in heart failure, other than Paradigm, that we had in the last 20 years. And basically, there was overall improvement in primary outcome, mortality, overall reduction of hospitalization for heart failure, death from cardiac disease, but also overall death. And the effect starts as early as about 4 weeks. Now we have also, so if you were to translate this, whether this is meaningful impact for a clinician, we look at necessary number to treat. Basically, the necessary number to treat is about 20 to 1. This is for cumulative heart failure admission, cardiovascular death. Just to put this in perspective, when we had the SAFE trial or the SOLVE trial for ACE inhibitors, that was about 40 to 1. So this is actually very significant. This applies to heart failure admissions. Death from cardiovascular disease goes up to 50, and death from any cause. I'm going to give you another reference. Necessary number to treat for statins in secondary prevention after heart attack. It's about 70 to 90. So this is actually extremely strong signal here. And so if you were to look at the impact of all medicines that we have shown improve survival in patients with heart failure with reduced ejection fraction, we start with the baseline mortality about 35% by 2 years. If we add gradually an ARNI, angiotensin receptor blocker combined with neprilysin inhibitors, a beta blocker, mineral receptor corticosteroid antagonist, or SGLT2 inhibitor, we can drop that risk by 75%. So I tell my patients, I know there will be a lot of drugs, some of them huge financial strain, but I can save you, if you ask me 6 months from now, 3/4, 75%, you're going to be better, live longer. In average, this patient also buys about 6.5 years of life if we can get them all on all these drugs. So this is extremely significant, made major impact. When you look at overall, more recently, we also have an empagliflozin-based trial, which is Emperor reduced trial that showed a similar, actually beneficial effect. And this is a meta-analysis that Dr. Packer has published. And again, when you look at why does this happen, really, most important beneficial effect in terms of heart failure was related to a dramatic impact on the renal outcome and prevention reduction of GFR. As a matter of fact, the biggest impact was those with GFR between 30 and 60 mLs. So if they are too advanced, they didn't make an impact, but if they are too early, probably did not follow them long enough. The trials were stopped because they were beneficial. But 30 to 60 mLs right there between chronic kidney disease, stage 2 to 3B. So that's, keep that in mind. And By far, doesn't matter which version we look, whether it's diabetes, kidney disease, no kidney disease, independent of diabetes, these medicines show that at least in terms of time to new onset or new admissions for heart failure was reduced by about 33%. So now I'm going to add on one more piece of information here. Turns out when we block the SGLT2, which is in charge of 90% of normal glucose reabsorption in the proximal tubule, the SGLT2-1, which is normally 10%, gets upregulated in this patient with diabetes and heart failure. This was actually demonstrated by Dr. DeFronzo, who is actually a chief of diabetes and has been doing clinical translational research at University of Texas in San Antonio. He's actually the father of discovering these agents, the glyphosines. And basically, we get compensatory upregulation of the type 1, which glucose transporter, which is not very effective, but if you have a lot of it, actually can still overcome what you did with your SGLT2. So if we were to look into, okay, let's get more glucose and sodium excretion in the kidney, then let's block both. And sotagliflozin is actually one of those drugs that block both the type 1 and type 2 receptor. Now, type 1 receptor is present in the heart and also in the gut, so you have some potential side effects with diarrhea there. And indeed, we have two trials, the Soloist WHF trial and the SCORE trial. The SCORE trial is equivalent to the it's more of a cardiovascular prevention trial in those patients with diabetes, but the Soloist heart failure trial is actually anybody who came with acute decompensated heart failure as soon as they were about to go out of the hospital. It didn't matter whether it's systolic or diastolic, they actually were placed on this medicine. And it did improve overall the combined cardiovascular death, hospitalization, and ER visit for heart failure. There wasn't any difference in cardiovascular death or all-cause death between the groups. The catch was this is a small company who funded this, and basically the study was stopped early because of the lack of funding, but it would have been very fascinating to know whether blocking both of them makes a difference or not. We have some evidence. I know they submitted to see if it's FDA approved. I don't know if it's been approved yet. Now, what about heart failure and preserved ejection fraction? Probably the most significant trial that came out a few months ago is the Emperor preserved ejection fraction trial. It was fascinating. They defined preserved ejection fraction of more than 40%. So included this mid-range ejection fraction between 40 and 50, which one could make a case that those could be patients that are actually moving towards low or moving towards better in recovery. Either way, to me, that's a fascinating aspect. The good news is because they did include those patients, there was clear benefit in terms of overall outcomes of cardiovascular death and heart failure hospitalization. It starts as early as 4 weeks, but if you exclude those, but the benefit was only in those who, although this is post hoc analysis, and those who had an ejection fraction less than 55, 60. If it's over 60, the beneficial effect seemed to go away. So it's not too clear if is this a pure drug just for HFpEF, really the way it's defined, but at least we know it's currently actually has been approved to be used independent of the ejection fraction. We have a drug that's useful and added to spironolactone as HFpEF agents. At least we have two agents there and they can help. So in summary, the impact of SGLT2 inhibitors in cardiovascular and renal outcome trials drops a little bit the hemoglobin A1C. Really, as a matter of fact, it drops by 1% initially in 4 to 8 weeks. I guess everybody just gets compliant, including placebo patients. But then at the end of the study, it was only 0.2% difference. It does have a weight loss effect, anywhere between 6 to 10 pounds, depending on the patient. So that might be something you may want to tell the patient. Has minimal impact on the blood pressure, 3 millimeters mercury. Somebody who average blood pressure was systolic pressure was 135. Prevents MACE, although that's not its forte. The really forte here, about 25% relative risk reduction, is actually was related to heart failure with reduced ejection fraction and kidney outcomes. But for those who have high risk of dying from either heart failure or progressive kidney disease, then it does improve cardiovascular death too. And we still have other studies that need to answer the questions about the impact on heart failure with preserved ejection fraction. We have a dapagliflozin equivalent trial that hopefully we'll find out. But bottom line is, from Dr. DeFronzo, who is the one who invented them, He said this is not a drug for diabetic specialists. This is a drug for cardiologists, and I would say a drug for nephrologists, and a drug because of its plethoric actions, working, preventing end organ damage from diabetes, liver, heart, and kidney, is actually for internists and for everybody. And of course, it's a new drug, so you're afraid. I'm going to introduce this. What shall I expect? And basically, the main side effects are genital infections, which those usually with poorly controlled diabetes, they have excessive glucosuria. They're going to have higher risk of urinary infection. Diabetic acidosis is minimal. It's only type 1 insulin-dependent patients you have to worry about it, and I will always engage the endocrinologist before I start to place them on that, because they'll have probably reduce some of their, adjust their diabetic medicines. The risk of amputation turns out is not really there. I would say the most important risk is actually financial at this point. I call it the financial diabetes, plenty of sugar around and no access to it. I would say the pre-certification and the cost is still quite high, even if you have insurance. And probably we are able to get this about 25% of the patients with huge effort on this. And I'm going to finalize with updated guidelines. American Heart Association updated this, but bottom line is it was suggesting we should start one drug at a time. And we are not really making an impact with that because very few patients are actually on target GDMT therapy. And they are not on target GDMT therapy because maybe the strategy is wrong. If we do one at a time, it takes a year. We know that actually, and you don't start it while they're in the hospital, actually most of them, 75%, will not be on GDMT at the end of the day. And so the really most updated ACC and AHA guidelines from actually last week shows that we should start with this, have a strategy where we can start as many as we can, whatever you feel comfortable, adjust it for a given patient's case scenario. Start with low dose, all 3 or 4 of them, and then gradually go up, provided, because the benefits is as early as 4 weeks for almost every drug that we showed that improves mortality and morbidity. Or you can start with 2 drugs, like Dr. Milton Packer suggested. This is where you get the biggest bucks for the money. Beta blockers, SGLT inhibitors, and the least side effects, and then you can start in second steps with ARNIs or MRAs. It doesn't matter. Either way, we look forward for more clinical trials that relates to either primary prevention or HFpEF. As I mentioned, look forward to the liver trial, which is the dapagliflozin evaluation for HFpEF. And I'm going to end here and be happy to take any questions. Yeah, Bob, go ahead.
Hey, as always, like a ton of data from you.
Yeah, I tend to overdo it.
We have to sort of digest all this. So I have 3 things. One is just to remind everybody, we are sort of in hybrid most of the time. For the rest of the year, we'll have some speakers who don't want to travel to Atlanta. So please keep an eye on the schedule, and we'll let you know every week. We send out a thing on Thursday to let you know whether this is in person or not. A comment and then a question. The other, the challenge with this is really what is the mechanism? I mean, we really. That's right. It's all hypothesized. That's right. And the other mechanism that's been thrown around is ketones, right? Is that these are ketogenic, and obviously with DKA being a potential side effect in insulin-dependent people, and the ketones, both in the heart and in the kidney in heart failure, we know that glucose and fatty acid metabolism are limited, and so it's been proposed another mechanism, right, is that ketones can be an energy source and alter cardiac metabolism.
That's right. It triggers a fasting cell into state.
And in the kidney too. So the question for you is the effect of BMP as an entry. So the one trial you pointed out, and I'm not sure about the others, required a BNP sort of 600, 900. So what about the stable patient who you've, done traditional, guideline-based medical therapy, and their BNP is pretty good. It's down at 100 or something. Is there still an effect of SGLT2 inhibitors?
I think I don't have exactly the data. What was the percentage of patients who had stable normal BMP? They haven't shown that. They just showed an average. But the entry criteria was you could include anybody who's got diabetes and or type, at least in the diabetic trials, but also non-diabetic trial, anybody who's had heart failure admission in the last year. Now, I don't know, was a day before last year or right within the last week or so. But one can assume some of them were stable. It's a good point. If BNP is normal, they're stable, they're fine. I think it's fine. To me, the guidelines said you put everybody now as a first line on top of the others. I don't think, particularly if it costs so much. If I see somebody, I put them on the standard even without dapagliflozin if it's a burden, and then repeat the echo in 3 months. If it looks like it's improving, you may not necessarily want to do that, but if it's not, and if it's a financial cost. Now, if there is no financial burden, the guidelines tell us everybody should be on it, yeah. But you're right, I'm not sure about the proof for that, whether people are stable, normal BNP, and haven't had any heart failure, hospitalization reason, they should be on that on top of the other. Yeah, I don't have an answer to that. Yeah.
Stan Sherman, is there a dose-related effect on some of the heart failure, or is just whatever dose was in the study?
So the question is whether the dose makes a difference. There are a couple of these studies that had actually a titration program. For example, empagliflozin was 10 milligrams versus 25 in the Emperor trials. It showed that actually there was no difference between 10 and 25. As a matter of fact, it's approved for 10. But we also have 25 pill. And for the same for canagliflozin, the dose range was between 100 and 300. Turns out final dose is 100. So you can go with the lower dose that it does the same impact. I would say if insurance pays for the 25 and somebody's 300 pounds, probably I'll go with the second dose. But we have some flexibility there. It turns out it costs the same whether it's 10, 25, or 100 versus 300. So.
There's a question in the chat by Dr. Balk. He wants you to comment on the earlier slides regarding the Frank Anania data on sugar. So, for example, fruit is supposed to be good. Fruit has fructose and glucose. So is he going to get fatty liver because of eating fruit and heart failure? Or is the real issue really just the excess calories or, things like high fructose corn syrup from sodas, et cetera? So could you comment on that?
So that's a topic for a whole other lecture, and obvious part of it is debatable. But there is nothing wrong with, I don't think anybody will get diabetes if they eat, because they eat 100 apples a day. The key is eat the apple, don't juice it. So in other words, if we eat unprocessed, that means as it comes from Mother Nature, it comes with the fiber. So yes, an apple will have about a equivalent of 8 teaspoons of sugar per apple, as a matter of fact. But half of it is bound to the fiber. So as long as you eat it with that, actually it goes to your healthy probiotic bacteria in the gut, which is made for them to eat, and then it will be less. Now, of course, if you want to, you can prove me wrong and eat 100 apples a day and see what happens. But in general, there is no question about what it comes from Mother Nature, fruits versus, the key is here not to process. It's the processing that enriches a lot of fructose, but also gets rid of the fiber, which is designed to actually protect you from side effects of the fructose and glucose and some other stuff. And nobody cooks anymore. We just buy stuff that's labeled. Everything is, if there is something that's good in it, we're going to create immediately a pill or a extract. And that's just arrogance, and I think that's the main reason why we got to where we are. Yeah.
Thank you. Dr. Smith has a comment that when initiating SGLT2 inhibitors and ARNI therapy, in patients, we need to consider potentially reducing the loop diuretics. Yeah,
that's a good point. And we've had some patients, particularly the ones who are actually getting on the compliance with the sodium, in the diet. Yes, I've noticed some of them. We should consider reducing the diuretic dose or frequency for those patients. And we warn the patients, particularly if they lose weight and they stay stable. Yes, it's a very good point, Andy.
Combining, once you start somebody on SGLT2 inhibitors, are you also adding GLP-1 because it's a completely different sort of mechanism with the incretin effect? Do you think that the combination of the two will be more beneficial?
Right now, I'm not touching the GLP-1 receptor agonist. We stall enough. The SGLT2, we have enough. It's comfortable. The GLP-1 antagonist, I will work with the endocrinologist. Particularly, it helps a lot with the weight loss for certain patients. I would not prescribe by myself, for sure. And the reason is we don't really have enough. The beneficial of GLP-1 receptor agonist on cardiovascular disease, really, it's very mild compared to SGLT2. One is less than 15%, mostly stroke. It's unclear whether really no heart failure benefit. This is not a drug, it's IV, sub-Q. This is not a drug that I feel comfortable managing as a cardiologist. Although if I see more, they make it easier, and I see more heart failure benefit, there might be something we may venture there. But we don't have those studies. If there's anything, it's negative data for that. Yeah.
That's interesting because we're starting to use that a lot just for weight reduction benefits.
Yeah. So in preventing cleaning, it's excellent. You get comfortable. I'll be happy to share some of your experience and learn from it. But just remember, we have kind of dual-edge kind of data with these agents. Now, if somebody's preventive, not advanced cardiovascular disease, that's a different story, and that's appropriate. They're very potent, probably the most potent agents we have now if they're used properly, to lose weight.
The preceding program is copyrighted by Emory University.